Gresham College presents 21st Century Threats, HIV, AIDS by Dr. Markus Haacker.
Good evening. My name is Markus Haacker, and today I will give the first lecture on 21st Century Threats, HIV/AIDS. Even though I come from the London School of Hygiene, I'm actually not a medical person. I'm not even a health economist. I grew up with macroeconomics and development issues, and I came across the issue of HIV/AIDS for the first time in 1999, professionally. And at that time, I had just joined the International Monetary Fund as an economist. And as my first assignment, they put me in charge of the Swaziland desk. And that put me into a position of having to address how do you actually provide economic analysis and economic policy advice in a country where 25% of the adult population is infected with a deadly disease, no treatment on the horizon at that time, so on their way out within the next couple of years. And this issue has stayed with me ever since. I later worked with people at the IMF, the World Bank, UNAIDS, ILO to provide some answers on the macroeconomic dimension of HIV/AIDS, how to provide some policy advice to, say, Ministry of Finance in a country that is affected by a severe HIV epidemic. And as the global response to HIV evolved over the last few years, I have worked more closely with institutions like the World Bank or UNAIDS to better understand the fiscal consequences of HIV/AIDS and the national response to it, and inform more specifically the financing and the design of HIV programs. Today's presentation builds on this experience. It describes HIV/AIDS as a complex health and development challenge, or as the lecture series puts it, a 21st century threat. In addition to the immediate health impacts, we will be looking at the macroeconomic, distributional, and social aspects of the epidemic, and discuss the global response to HIV/AIDS from this angle. HIV/AIDS is a relatively new disease. It is thought to have emerged as early as the 1930s. However, the first cases of HIV were documented only in the early 1980s among gay men in the United States. Soon after, wasting disorder, which had emerged in Eastern Africa, in particular Uganda, was linked to AIDS, and by 1984, this human immunodeficiency virus was established as the cause of AIDS. By the mid-1980s, cases of HIV infection among heterosexual people became more common in the United States and increasingly across the world. The first drug for treating AIDS was approved only in 1987. Let's take a look at the global course of HIV since then. As early as 1990, just about 10 years after the disease has come to the attention of the global public, already there were about 9.5 million people living with HIV/AIDS, and the epidemic has continued to escalate from that point, increasing to this day, reaching about 26 or so million people infected by 2000, and this number has now increased to 34 million. HIV incidence has escalated rapidly from the 1980s well into the 1990s. peaking at about 3.4 million people annually. It has since come down somewhat, but still today about 2.5 million people are infected with, 2.2 million people are infected with HIV each year. And over the last years also, HIV incidence has not come out as quickly as previously. Over the last few years, a new development is apparent in this figure, and that is the decline in HIV mortality, which of course reflects the global scaling up of treatment. As late as 2004, very few people across the developing world, about 100,000, were receiving any treatment. And expanding access to treatment was a priority of the global response to HIV and the focus of the World Health Organization's 3x5 initiative, aiming to extend treatment to 3 million by 2005. And this drive to extend treatment was largely successful. By 2010, it is now estimated that 6.6 million people across the developing world are receiving or were receiving treatment, and as a consequence, the number of AIDS deaths was reduced by about 1/3. However, the WHO and UNAIDS estimate that at least 15 million people were requiring treatment in that year. This means that less than 1/2 of people in need of treatment were receiving it. And even if one takes into account that actually many people who would require treatment are not aware of their HIV status, this describes a situation which still is very far from universal coverage of treatment. One of the peculiar, if you will, aspects of HIV is that the perception as a major global health and also as a major global development challenge has motivated an unprecedented global response. The Joint United Nations Program on HIV/AIDS, in short UNAIDS, was established in 1995 and charged with coordinating the global response, and the United Nations have held several special sessions on HIV/AIDS and have placed HIV/AIDS highly among the Millennium Development Goals. Another innovation in the global public health or development architecture that the impact of HIV has motivated is the establishment of the Global Fund to fight HIV, tuberculosis, and malaria, which is largely funded by national governments, and the objective is to channel this international support to national health programs, in particular HIV. 60% of the funding that comes from the Global Fund is dedicated to HIV programs. The exceptional role that the international community has attributed to HIV is also apparent from the level of the financial support to the global response to HIV. UNAIDS estimates that HIV spending from public sources amounted, so all spending by governments, all spending supported, say, by institutions like the United States government through its HIV program, all this spending from public sources amounted to about 16 billion across low and middle income countries in 2009, of which external aid accounted for about 1/2, 7.6 billion US dollars, which is a staggering number. This means that HIV disbursements accounted for 5% of all global development assistance and for 38% of all disbursements in the areas of health and population policies combined. In spite of these achievements, the global response to HIV appears to be in a state of crisis. HIV funding has not kept pace with the increasing costs of the global response to HIV, and most visibly, recently, the Global Fund has postponed its call for funding proposals because of concerns about its own funding sources. As a consequence, the head of the Global Fund has subsequently resigned. Now, now I come to a question of what explains or justifies this exceptional status of HIV as a global challenge, or as the title of this lecture series puts it, as a 21st century threat. To find an answer to this question, I will look at two aspects of the epidemic. One, the contribution to the global burden of disease, and second, the distribution of the epidemic across countries. And my reasoning is that an epidemic qualifies as a significant global health challenge if its cause high according to two criteria. First, of course, it needs to contribute significantly to the global burden of disease, and it needs to be it needs to be correlated with other development challenges. This second criterion deserves some explanation as it transcends the sphere of public health. So we are now taking much broader development perspective. However, it does reflect a powerful motive behind the global response. So in order to understand the global response to HIV/AIDS, it is necessary to also take into account this, that it is also perceived as a development issue. The vast majority of people living with HIV are located in developing countries, and unsurprisingly, a disproportionate share of deaths occurs there. At the outset, it is therefore a legitimate concern that HIV/AIDS is widening global disparities in living standards, and that it does undermine the development prospects among some of the most disadvantaged countries. From a global bird's-eye perspective, the impact of HIV/AIDS is fairly small. HIV-related mortality accounts for about 3% of all deaths in 2008. Over the last 20 years, to understand what this 3% actually means, but one way is comparing it to communicable diseases, and by that count, HIV globally accounts for about 1 in 7 deaths from communicable diseases. Globally, the major cause of death is non-communicable diseases, and deaths from non-communicable diseases are about 20 times higher than HIV. If you look at it over time, mortality has declined by about 14% globally over the last 20 years, and would have declined by these numbers by 17% in the absence of HIV. That means that this HIV/AIDS perceived as a global health shock has wiped out health gains in the equivalent of health gains in other areas that have been achieved, that are normally achieved over a period of 4 years. The profile of HIV deaths, however, is peculiar because most deaths occur among young adults. So to get an idea of the impact of HIV globally, one obtains a much sharper picture looking, for example, as the World Health Organization does, at the impacts of HIV in the 15 to 59 age group, which excludes both infant and child mortality, and it excludes most deaths linked to typical old age related conditions. By this count, the impact of HIV is much more pronounced, accounting for 8% of premature adult deaths. Now, one important aspect of HIV is that the epidemic is concentrated in a number of countries, especially in sub-Saharan Africa. Of 33 million people living with HIV globally, 23 million are now located in sub-Saharan Africa. This is significant also from a development perspective because this region includes many of the poorest countries globally. And so, at least according to regional averages, it appears that the health impact of HIV does exacerbate economic disadvantages in living standards. The role of HIV across sub-Saharan Africa is also apparent from the mortality data. HIV accounts for 13% of all deaths there, and that probably is an understatement of the impact of HIV in Africa, because other causes of death and therefore crude mortality are also much more prevalent in Africa. So if one looks at the absolute contribution of HIV to the burden of mortality in Africa, this is about 5 times higher than the global average. As noted earlier, crude mortality is a mixed bag as far as the contribution of HIV to the burden of disease is concerned, as it also includes the young and the old age groups. So if we look at the burden of disease, again in this 15 to 59 age bracket, actually the impact of HIV in sub-Saharan Africa comes out very high, accounting for more than 1/4 of all adult deaths across the region. And with that, one word of caution. While it is well known that the epidemic is concentrated in sub-Saharan Africa, at the same time there are very large differences in HIV prevalence across countries within the region. It includes a number of countries like Eritrea, Nigeria, Mauritania, where HIV prevalence is actually on about the same level as in the United States, less than 1%. On the other hand, the region includes a number of countries where HIV prevalence exceeds 10%, and a few countries where HIV prevalence is higher than 20%. So while it is true that the HIV epidemic is concentrated in sub-Saharan Africa, it is also distributed very unevenly across Africa. One of the aspects of the threat of HIV/AIDS is the extent to which it is bound up with other development challenges. And let's take a closer look at this economic dimension. It is also a good opportunity to compare HIV with some other diseases commonly tied up with economic development or poverty, such as tuberculosis or malaria. What I have prepared here is a figure that shows the contribution of these 3 conditions to mortality across low-income countries. That's about the 35 countries globally with the lowest level of income, and it includes many countries with high HIV prevalence like Malawi, Mozambique, Kenya, and the next highest category, which is lower middle income countries, including some HIV hotspots like Swaziland or Lesotho. What this figure shows us is that infectious diseases play a disproportionate role across these developing countries, where accounting for about 90% of all deaths across developing countries. Looking at the role that tuberculosis, HIV, and malaria play, but tuberculosis is not really a typical disease which is tied up with low level of development. Actually, the burden of tuberculosis deaths is much more pronounced in the economically more advanced of these developing countries, in the lower middle income countries. HIV/AIDS also is not a straightforward disease of development. Actually, HIV/AIDS deaths are concentrated in low-income countries, but overall, HIV mortality is not. It's similar to other infectious diseases, and actually, 75% of HIV deaths occur among low and lower middle-income countries. That is actually less than for infectious diseases overall. Probably this could be misleading because of the large weight of South Africa, which is not included there, but still, compared to malaria, where 99% of all deaths occur in this country group, HIV/AIDS is much less concentrated and among low-income countries and tied up with economic disadvantages across countries. Now, I don't mean to conduct a horse race with this. What I'm trying to come to grips with here is the health and development challenges posed by HIV, and the extent to which the health impact of HIV is tied up with economic development is important because it's meaningful in terms of the country's capacities to respond to the epidemic, and in terms of the impacts of the epidemic on the household level, and in terms of the motive for support along the lines of development assistance. These broad assessments of the impact of HIV by region or income do not capture one critical aspect of HIV, and that I noted that earlier for Africa, is the fact that it is distributed very unevenly across countries. I had noticed that HIV prevalence in some sub-Saharan African countries is lower than in the United States, but the continent does also include some HIV hotspots with prevalence over 20%. So to illustrate the extent to which HIV is concentrated in a few countries or regions, I compare it to the global distribution of income. Most people would have a broad idea or could visualize the global distribution of income and would consider it uneven. Looking at the distribution of people living with HIV, which are lined up below the blue curve here, it appears that the distribution of HIV is much more concentrated across countries. For example, the richest countries with 5% of the global population control 28% of global income, and countries representing 9.4% of the global population control 50% of global income. With HIV, the worst affected countries with 1% of the global population represent 22% of the global population of people living with HIV/AIDS. So this is an extreme concentration of HIV in a handful of countries, which can be seen at the far right of this figure. Actually, the area under this graph is proportional to the number of people living in the respective countries. So you see that as soon as we come out of about this country range, about 1 billion of the global population, largely in Africa, there is not much HIV. There are not many people living with HIV anywhere else. To take this perspective of the impact of HIV across countries further and understand the implications for the development impact, I am reorganizing this figure. So now, instead of lining up the global population by income and lining it up by HIV prevalence in the second figure, now I am lining up people with HIV by income levels. And what we get out of this exercise is, well, we see that there is a cluster of countries with high HIV prevalence at a low level of development. This is about the set of low-income countries here, and but even here, countries with very high HIV prevalence, such as Lesotho, are neighboring countries where this cannot be seen very well because it goes up and down so quickly, coincide with countries where HIV prevalence is close to zero. And then well, another aspect of the global distribution of HIV is that there is not that much going on among high-income countries. China, India are these two flat lines here. But in case of HIV, we also see that there are at all levels, across all levels of development among middle-income countries, we see countries with very high HIV prevalence coinciding with countries with low HIV prevalence, and overall HIV, as we have seen, is it is not clearly associated with lack of economic development. It is it occurs across the global income distribution, and I think the most significant characteristic of HIV that comes out of this figure is again this extreme concentration of HIV in a number of countries. This is also evident if we compare HIV with malaria. Now the red curve represents the global burden of disease of malaria deaths across countries, and the blue line, the global burden of disease in terms of HIV deaths. And even though malaria is much closer aligned with lack of economic development and is exacerbating economic and other social challenges in developing countries, well, there are three differences between malaria and HIV. One is the burden of disease is is much higher on average for HIV than it is for malaria. And well, the second point is, well, malaria is, as observed earlier, concentrated more closely among these low-income countries. And the third point is, and that is a consequence of this extreme concentration of HIV in a number of countries, we have countries where HIV-related mortality is of the order of magnitude of close to 1% annually, and in extreme cases even much higher. So the extreme concentration of the impact of HIV prevalence also translates into a catastrophic impact of HIV on mortality in the countries worst affected. Now, where does that take us from this discussion of HIV across countries, across developing countries? I draw three lessons. One is that HIV is tied up with other development challenges. HIV prevalence and especially mortality tend to be higher in low-income countries, and that means that the epidemic is exacerbating or reinforcing deprivation in other areas of development. It also means that much of the epidemic takes place in areas where the capacities of health services are relatively low. However, in this regard, HIV/AIDS does not stand out from other infectious diseases, which also vastly disproportionately occur in developing countries. The third lesson, again, is what really distinguishes the impact of HIV from, I think, any other disease that is associated with a low level of development, is that it is so extremely concentrated, with 1% of the global population accounting for 22% of people living with HIV, and that as a consequence of that, HIV is a massive challenge in a number of low-income countries with high HIV prevalence. And this also explains why the focus on HIV in countries like South Africa or Botswana, which are among the most successful developing economies anywhere, but where the devastating impact of HIV has reversed health gains achieved over many decades, and where managing and financing the response to HIV represents a steep challenge, even given their economic and fiscal resources. We are now turning to some of the countries with very high HIV prevalence, where the health and the economic impacts are most apparent. The most immediate and serious impacts of HIV, of course, occur in the area of public health, and this figure here amply illustrates this, which shows estimates of how life expectancy has been evolving over time in 8 countries with very high HIV prevalence. Southern Africa and countries like Botswana, Lesotho, Namibia, South Africa, and Swaziland used to be a very successful region in terms of health achievements, with life expectancy between 40 and 47 years in the 1950s, and then this has increased very steeply to the 55, even 60 years range by 1985, but since then life expectancy in this region has dropped back to the level of 1950. So basically half a century of gains in state of public health were wiped out by the impact of the epidemic. And also if you look at countries like Malawi or Mozambique, where HIV prevalence is much lower than in these hyper-epidemic countries, we see that HIV has taken out about 10 years of life expectancy. One positive note maybe in this dire picture is the reversal that takes place over the last few years, which is the consequence of the increased scaling up of treatment. However, even in countries, say Botswana, Namibia, which were leading in terms of extending access to treatment, life expectancy still is much lower than before the impact of the epidemic, and whether a person living with HIV obtains treatment or not, life expectancy still is severely reduced. Now, what are the economic consequences of this health shock? According to the available macroeconomic data, the impacts of HIV on GDP per capita are very small, and if this picture is confusing and you don't get the message, I mean that is the point here. What I am comparing is how GDP growth has evolved in sub-Saharan Africa to how GDP growth has evolved in countries with high HIV prevalence or the non-bold lines. And from this figure and also from the econometric evidence, we don't see a difference between countries with high HIV prevalence and with low HIV prevalence, even in these very large countries, and there were some outliers like Zimbabwe, but there are good reasons why catastrophic economic policies, why growth has dropped in Zimbabwe, or Botswana, where the expansion of mining has slowed down. So even if I do not take into account these alternative reasons, I don't see an impact of HIV on economic growth in this region. And this empirical evidence, this intuition is also consistent with more informal evidence, for example, from business surveys for business managers in South Africa. HIV/AIDS would typically be rated, it would appear on a list of things they would be concerned with in terms of the business outlook, but usually on the bottom of the 10 issues they would be concerned about. So this is fairly small, or at most medium potatoes for business managers in South Africa. The solution to this puzzle, that this catastrophic health shock coincides with a maybe trivial impact on GDP growth, is I believe that the impact of HIV differs across sectors. In the most valuable sectors, value added per worker is very high. For example, one example from Namibia, in the mining sector in Namibia, value added per worker was, in 2004, was $72,000 per employee, which is 25 times the level of the value added in agriculture. And compared to these $72,000, the cost of providing treatment to employees and even their families, or taking measures to avoid health-related disruptions to the production process, are just trivial. And this example from Namibia is relevant across Southern Africa, which is a region where value added tends to be concentrated in a few sectors, and it is one of the regions where income inequality is among the highest globally. So I argue that because of this high level of economic inequality, because the sectors which basically make up GDP in countries like South Africa, Namibia, Botswana can protect themselves from the impact of HIV, that because of this, the macroeconomic impact as measured by GDP per capita is trivial. This coin, however, has two sides. While high inequality mitigates the macroeconomic impact of HIV/AIDS, at the same time it exacerbates the social consequences of the epidemic. This is an area where the evidence is sketchy and does not generalize well, so I can only offer some conjectures. HIV/AIDS empirically has been shown to have a significant impact on the productivity of manual labor and on crop patterns. Agricultural and other manual workers or subsistence farmers, however, tend to be located at the lower end of the income distribution and be reliant on their labor incomes. Additionally, a loss in income at or above the poverty line has immediate consequences for the well-being of household members. The risks to incomes for households at the lower end of the income distribution are exacerbated by inequalities in access to health services. In South Africa, private health insurance is de facto reserved for the highest 3 of 4 deciles of the income distribution. So while the poorest households spend 1.3% of their incomes on health out of pocket. The richest households spend 1.8%. However, what accounts for this massive difference in private health spending across income groups in South Africa is the fact that the richest households, the richest decile, additionally spend 4.7% of their incomes on health insurance. And as a consequence of this, while the incomes between the richest decile and the poorest decile differ by a factor of 17, private health spending differs by a factor of 66, and spending on private health insurance, which is a way of acquiring health services which is nicely spread over time and ensures against immediate need, spending on private health insurance differs by a factor of over 200. As a consequence, poor households are economically vulnerable to the costs of illness. A recent example from Jamaica illustrates this point. For households seeking health care because of an episode of illness, the private costs of services and drugs, on top of free public services, amounted to 1/2 of per capita income for the poorest quintile, but only 20% for the richest quintile. Additionally, the utilization of health services differed across income groups, whereas 82% of people experience an episode of illness in the highest quintile were accessing health services. It was only 2/3 in the lowest quintile. In this environment, HIV does impoverish poorer households. It is a persistent health condition, not only an episode of illness, and the costs of accessing health care are probably above the costs of average health conditions. In summary, while social inequalities played a role in mitigating the macroeconomic impacts of HIV/AIDS, the epidemic exacerbates social inequalities. In this context, access to HIV-related services has a strong social and development component in addition to the public health consequences. The prospect that the macroeconomic impact of HIV is very small may appear offensive to some who take note of the devastating health consequences. This irritation is justified, but only when living standards are equated to GDP per capita, which is a good idea in most cases because economic process tends to coincide with improvements in health, education, or other dimensions of well-being. This link, however, is broken in countries facing a massive health shock like major HIV epidemic. There are two approaches which have been developed to assess the consequences of a health shock to living standards. One is the Human Development Index promoted by the United Nations Development Programme. This combines measures of GDP per capita, life expectancy, and educational standards. As an example, for the consequence of the impact of HIV/AIDS, let's consider Swaziland. In 1980, Swaziland was on par with countries like China and Guatemala, and actually, using this Human Development Index, it has developed more quickly than these countries. However, since 1990, the level of human development in Swaziland has declined in absolute terms, and it is therefore no longer on par with China. Instead, Swaziland's development index is on a level similar to Pakistan's, where GDP per capita is about 1/2 of the level in Swaziland, or even Nepal, where GDP per capita is 1/5 of Swaziland's. The other approach starts from individual valuations of health risks, more dangerous occupations demanding higher salaries, and such data can be interpreted to obtain estimates of the costs of a health shock in percent of GDP. Now, I apologize for the quality of this table, but what this table does, it translates the impact of HIV/AIDS on life expectancy in an economic cost, which is an estimated economic cost, which is measured in percent of GDP. So what we get out of this, kind of analysis is, say, there are some countries, Kenya or South Africa, where the impact of HIV on mortality were so strong that over the last decades, actually living standards have declined in absolute terms, in spite of sometimes large contributions of economic growth. And if we look at the impact of HIV overall accumulated, we estimate that the costs of HIV, say for South Africa, are equivalent to a cost of 1/2 of the level of GDP. And those are staggering numbers, but a few slides back, we've also seen that in this region, HIV/AIDS has wiped out any health gains as far as life expectancy is concerned, which have been accumulated basically since the 1950s. So what, from this perspective, a health shock of an enormous magnitude is also translating into an enormous cost in terms of living standards. Now, what I have attempted to communicate so far is a perspective of HIV as a complex development challenge, which can be described as the most severe adverse global health shock in modern times. Unusually, the impact of this health shock is highly concentrated in a small number of countries, and while the macroeconomic consequences of HIV are unclear and probably small, the epidemic exacerbates social inequalities. These concerns about the health and development impacts of HIV have motivated an unprecedented global response, which in some areas has been a major success. Most visibly, the global response has succeeded in extending treatment to over 6 million people across developing countries. It has been successful in saving millions of lives and in improving the living standards of people living with HIV and their families. From an economic development angle, the global response to HIV has also mitigated widening inequalities in living standards across countries, and also in light of these differences in people's ability to access health services, it has also mitigated inequalities within countries. The global response to HIV, however, is built on a business model that has turned out to be unsustainable. In many countries, the national response to HIV depends on external funding. Spending needs continue to increase steeply, largely as a consequence of increasing access to treatment. As mortality among people receiving treatment is much reduced, and there are still large numbers of people each year newly seeking treatment, the number of people receiving treatment and the costs of the national responses to HIV and of the global response is projected to increase steeply over the coming years. On the other hand, new commitments from donors have stagnated over the last years, and actual disbursements have been declining. So this equation does not add up, and institutions like UNAIDS or the Global Fund are now under intense pressure to improve the cost effectiveness of HIV programs and partly through this to win over increasingly skeptical or cash-strapped donors. This situation also puts the gains achieved by the global response to HIV at risk, not only in terms of the gains achieved in extending access to treatment, but also in terms of containing reversals in living standards among the least developed countries. Not surprisingly, countries with very high HIV prevalence spend more on their national HIV programs, both absolutely and relative to GDP. However, according to these data on HIV spending, the most significant determinant of the challenge that countries are facing is not the HIV prevalence, it is GDP per capita. Most countries with a very high level of HIV spending in percent of GDP or relative to government revenues are low-income countries. And these low-income countries facing a high financial burden include quite a few countries where HIV prevalence is well below 10%, so far lower than in the hyper-epidemic countries. The donors so far have recognized these challenges, funding over 90% of the costs of national HIV programs in least developed countries and a steadily declining share of the costs of as GDP per capita increases. So as we get to countries like South Africa, they still fund a substantial share, but much lower than in this group. As a consequence, the domestic fiscal burden of financing HIV programs have been distributed fairly evenly across countries, with few countries where the domestic financing burden exceeds 0.3% of GDP. Now, where do we go from here? One obvious consequence of the current predicament is the need to transform the global response to HIV and improve cost effectiveness. The global response to HIV has been innovative in creating new institutions to coordinate the policy response and its funding with UNAIDS and the Global Fund. However, in many countries, the management of the national HIV program remains accountable to multiple donors, and much of its staff dependent on project funding. Reconciling the different stakeholders and coordinating between the donor objectives and the national health and development strategies can be a challenge. Moreover, the global response to HIV took off in an emergency and learning mode. As experience accumulates, it is necessary and feasible to test interventions in terms of their cost effectiveness and consistency with national development objectives and tackle vested interests which have developed in a period in which money was flowing freely. One of the most complex challenges is reinforcing the drive to bring down the number of new infections. The global response to HIV has been rather successful so far in bringing down mother-to-child infections, in achieving safe blood transfusions, and reducing HIV prevalence among young people in many countries. It has been much less successful in reducing HIV incidence among certain risk groups, like men who have sex with men and injecting drug users. As a consequence, the epidemic in most countries now is characterized as a concentrated epidemic, and only few countries experience a generalized epidemic. However, as these risk groups play a large role in passing on the virus, including into the general population, this failure constrains further progress in reducing HIV incidence. Finally, external support plays a crucial role in low-income countries, and these countries are most vulnerable to a decline in external funding. Take, for example, a country in which external funding accounts for 90% of the funding of the HIV program. If external support declines by only 20%, and I've heard estimates that it may decline much more than that. If external support declines by only 20%, for this country, domestic spending, domestic support for the national HIV program would need to increase almost threefold. Therefore, avoiding disruptions in these countries as the global HIV financing architecture is changing will be a major challenge for the sustainability and also for the credibility of the global response to HIV. Thank you very much.
For more information, please visit www.gresham.ac.uk.